Hello, my name's Katerina Stivkova. I'm a neonatal trainee at the Royal Maternity Hospital in Belfast.
And my name is Dr Reynold. I'm a neonatology consultant, also working in Belfast.
Today, we will be talking about the Cerebral Function Monitoring, CFM. We will talk about when to use the machine, how to set it up, and afterwards we'll talk about interpreting the trace.
Setting up the machine and responding to changes in the output is often time critical. Therefore, it's important that every registrar to your doctor knows the basics of setting up and interpreting the machine.
Let's talk about indication for CFM.
If you think a baby should have the CFM applied, always discuss it with the attending neonatologist. CFM is usually reserved for infants of 36 weeks of gestation or older. It can be used in preterm infants, but criteria for interpretation are less well established. The main strength of CFM is in monitoring the pattern of the amplitude of the brain activity. In neonatal encephalopathy, the amplitude is reduced. The most common use for CFM in our unit is as part of an assessment for therapeutic hypothermia. CFM can also be used to detect seizures because ictal discharges usually increase the amplitude of the brain activity. But it's important to know that the sensitivity is limited, particularly for short or low amplitude seizures. CFM should be used in babies with suspected seizures when continuous EEG is not readily available, and in babies who are muscle relaxed, because they will not show clinical signs of seizures.
What about the duration of monitoring?
The duration of monitoring should be determined by the attending consultant. For babies undergoing cooling, CFM should be continued at least until rewarming is complete. Otherwise, monitoring should usually be continued until the background recording has been stable for 24 hours and there have been no seizures for 12 to 24 hours. For babies with a clinical history and examination findings consistent with moderate to severe HIE who do not initially meet CFM criteria for cooling, the CFM should be continued until at least 6 hours after delivery.
Now we're going to talk about setting up the machine. The one we use in our unit is an Olympic brains monitor. As well as the machine, we need to gather the neonatal hydrogel sensors, low impedance needle electrodes, a ChlorPrep cleaning stick, tape to secure the needle electrodes, and the measuring tape. This is all of the equipment taken out of its packets.
The first step in setting up the CFM is placing the electrodes. The OBM can be used in either 3-electrode, single channel, or 5-electrode, triple channel modes. In our unit, either mode is acceptable, but in this video, we will demonstrate the 5-electrode setup. The 5 electrodes include 1 ground lead and 4 EEG leads. Electrode placement is based on the same 10-20 international system used for full montage EEG. The 4 leads are C3 and P3 on the left and C4 and P4 on the right. Place your tape measure along a line joining the tragus of the ear to the vertex. The vertex is the uppermost part of the scalp. The C electrode location is 60% of the way along this line. On this model, the correct position is 7.2 centimeters from the tragus. You may wish to mark this spot using a surgical site marker. The P electrode is then placed posteriorly to the C electrode at a distance of 10% of the head circumference. In term babies, this is approximately 3.5 centimeters. You may wish to also mark this spot. Correct electrode positioning is important. Electrodes positioned too closely together will produce lower amplitude readings. Next, let's talk about placing the electrodes. In this unit, needle electrodes are the default choice because they produce reliably low impedance values. But hydrogel electrodes should be used if needle electrodes are contraindicated. Contraindications to needle electrodes include prematurity, active bleeding or coagulopathy, and significant scalp injury, for instance, subgaleal hemorrhaging. Before inserting needle electrodes, prep the skin. Wait for the antiseptic solution to dry. Holding the skin taut, gently insert the electrodes subdermally, i.e. running just underneath the skin. The sharp ends should all point downwards, away from the vertex, so that the wires can be gathered together easily. Secure each of the needles in place using steri-strips. Using the under and over ribbon method allows the point of entry to be easily seen. That way, you can see if the needle has become dislodged. Repeat this process for the remaining 3 needle electrodes. The colour of the electrode lead is unimportant. Now, let's place the reference electrode. The reference electrode is used to suppress interfering signals detected by the other electrodes or their cables. Standard practice is to use a hydrogel electrode for the reference lead. This electrode may be placed either over the shoulder or behind the ear. In this video, we will place the hydrogel electrode over the shoulder. The machine we use in our unit is an Olympic brains monitor. Start by plugging in the machine. Then press the power button.
Connect the leads to the corresponding input ports of the data acquisition box. Once the program has loaded, press the record button located in the bottom right corner of the screen. Input patient details. Press Next. Select the 3 or 5 lead electrode configuration as appropriate. Press Start Recording.
Before we go any further, we should check the impedance. The impedance can be checked by pressing the omega button on the right-hand side of the screen. The impedance should be less than 10 kiloohms. The electrode impedance diagram on the left-hand side of the screen should display the real-time impedance values for each electrode. Use the AEEG channel selector icons to switch between single or dual channel views. The single channel view shows the cross-cerebral AEEG. The dual channel view shows the left and right AEEGs. For when assessing for therapeutic hypothermia, it is essential to rely on the single channel view in the case of any discrepancy. The navigation controls are below the AEEG graph. You can navigate the AEEG by dragging the graph horizontally. After reviewing the graph, don't forget to return to the live view by pressing the button on the right-hand side of the navigation controls. Let's talk a bit about interpreting the trace. A full guide to interpreting the trace is beyond the scope of this video, but we'll give you a few tips. First, start by assessing the signal quality. It is essential to begin by assessing the signal quality each time the output is interpreted. The signal quality may be reduced by impedance or artifact. Once you have determined that the signal is of sufficient quality, you need to classify the background activity. A minimum of 30 minutes of recording is required. In our neonatal unit, the primary classification scheme is the voltage criteria of Naki-Banal. To classify the AEEG, we need to determine the upper and lower margins of the trace. Sometimes the margins of the AEEG will have significant outliers. In these circumstances, do not include every brief fluctuation. Instead, consider where the upper and lower margins are for most of the time during the period being assessed. A normal voltage trace has a lower margin greater than 5 microvolts and an upper margin greater than 10 microvolts. A moderately abnormal trace has a lower margin less than 5 microvolts, but an upper margin greater than 10. A severely abnormal trace has a lower margin less than 5 and an upper margin less than 10. Let's talk briefly about seizures. Seizures are excessive synchronous neuronal discharges and therefore produce an increase in the amplitude of the AEEG. Electrical seizures should be suspected when a jump in the lower margin of the AEEG is observed. This is usually, but not always, accompanied by an increase in the upper margin. When a seizure is suspected on the AEEG, it must be confirmed by inspection of the raw trace. On a raw EEG, a seizure appears as a rhythmic pattern that importantly evolves over time. That means there is an onset, a crescendo, and an offset. When the monitoring period is finished, press the patient button. Then press close, followed by close session. Don't forget to turn off the machine.
Thank you for watching this video. Hope it's been useful.
For a complete guide to interpreting the CFM, please review the guideline accompanying this video. Bye.